So yeah, so today I wanted to sort of talk about some reflections on my year as a clinician scholar fellow and sort of think, talk about the future too. So conflicts of interest, I've studied at the University of Toronto, University of Ottawa, and McGill, and I've received salary support or awards from the universities in addition to the CHR. And I'm currently finishing PGY3 clinician scholar at the University of Ottawa. I don't think any of those conflicts of interest have impacted the work I'll be talking about today. However, I do have biases, so I used to think that clinical guidelines and clinical pearls and guidelines were legal gold. Now I have more of a balanced approach. So I will make specific acknowledgements for each of the different sections, but I do want to broadly acknowledge Dr. Mike Allen for the University of Ottawa, who's been extremely influential to me starting all the way back in medical school. So Dr. Mike Allen co-authors the BS Medicine podcast, which some of you may be aware of, in addition to the Tools of Practice.
With a pharmacist.
Yeah, he worked, pharmacists and a number of other family doctors, yes. And he talks a lot about how can we use evidence-based medicine in practice to help patients. And a lot of those words, evidence-based medicine and shared decision-making, will come back again and again during my talk. So I just wanted to provide a conceptualization of shared decision-making, which really talks to how I think of it too. So this was presented by Hoffman al. and JAMA in 2014, and in that framework, shared decision-making is really the symbiosis of evidence-based medicine and patient-centered skills. And it is essential for optimal patient care. So the broad objectives of my talk are to sort of discuss what does it mean to be a scholar, and to give some examples, and then how can also discuss how can scholarship be nurtured. So fellowship timeline is a one-year fellowship. For me, it was more like a year and a half because I did go on mat leave in between. So I started with an evaluation of the mindfulness curriculum to shake up some post-residency burnout. And then I took a deep dive into shared decision-making, evidence-based medicine, and the hidden curriculum to follow up on some medical school prescriptions. And then I started to think about the future and collaborate with Lamont on a new conceptualization of preventive care for multi-morbid patients. And then I'll wrap up with some reflection.
So is Emilie talking too fast?
Sorry.
Yes. Okay. Yes. Yeah. I think
okay.
For me. So just checking.
Stop me again because I'll try to be mindful. But
it's the French thing, isn't it? En français, on parle comment?
Yes. So all languages I speak very fast, and French, so first part, mindfulness. So for that section, I want to thank Dr. Doug Archibald, who has been sort of my overarching supervisor. So he's actually present in all the different sections, in addition to Heather McLean. So Heather McLean is the undergrad pre-fellowship director at the University of Ottawa, and her colleagues have a special interest in mindfulness. And they set up this great longitudinal curriculum for all 4 years of medical school to sort of help foster mindfulness. And I won't really talk about that curriculum because it is really Heather's work, but I do want to talk about the part that I was involved with, which was the evaluation. So Heather had set up a survey which had a number of questions in addition to 4 valid scales on mindfulness, empathy, stress, and resilience. And I was sort of asked to help make sense of the surveys. And the problem that I faced is that some of the survey answers didn't make any sense. So here I have an example of a very poetic survey. The sun is blue, the grass is green. The moss is not red, the flowers are pink. The sun is not blue. With a Likert scale going from strongly disagree to strongly agree. And some respondents would say disagree that the sun is blue, but they would also disagree that the sun is not blue. So lots of scales have those so-called reverse answers when sort of you're looking at the same thing but from a different side of the coin. And I have a number of questions like this. So this was not sort of an isolated incident, it happened all the time. And I wasn't too sure what to do with it because it was kind of a shame because obviously it didn't make sense. Which, so this is all about reflection, so it made me think about potential threats to validity. And in particular that perfect is the enemy of the good. So oftentimes when we set up studies, we want to capture a broad phenomenon. So we might collate different surveys which have been validated in your particular context. However, for a survey which is 20 questions might not give the same answers when it's placed at the end of another 100 questions. So the importance of context and whether we're creating threats to validity by sort of trying to look at the broad picture. And the other thing is money rewards are used all the time. And stop me again if I speak too fast. They're used all the time, and they've never been shown to actually increase survey return rates. But once again, are we creating a threat to validity by adding those money rewards? So if we have 100 questions to answer, if at 80 questions, we're tired, angry, hungry, you name it, if we know that we might get $20 gift certificate at the end, are we more inclined to answer those questions not having read the questions rather than stopping the survey? So once again, are we creating a threat to validity by adding those rewards which actually haven't been shown to increase the survey rate? So for that project, what did it mean to be a scholar? It meant reflecting, and taking a full use of the hindsight bias. So when we set up studies, we often have the best intentions, but nothing works as planned. That's just research. And so being a scholar is being really willing to look at how things were done, what worked, what didn't work, to do things differently the next time. So personally, I grew up in Toulouse. I guess I was still a little burned out at that time. And I wrote a burnout prevention app. So I wrote a grant, which I presented to Doug, who was very diplomatic. And instead of telling me I didn't know what I was talking about, he told me, why don't you write that book, Researching Medical Education? And I was like, sure, you know, I can read books. And then I didn't know I was actually going to discover a whole different vocabulary and words I had never heard about, such as post-positivism, constructivism, which didn't make any sense. And now, after a whole year as a clinician scholar, it makes a little more sense. So thank you, Doug. And to make sense of it all, so it involves many more books, many more discussions, and also participating in the Healthcare Education Scholars Program. So this program is set up by the Department of Innovation in Medical Education, DIME. It's a half day over a couple of months where educational scholars are taught a different education topic. And it's been really helpful in sort of the next project, which we'll be talking about, which is hitting very quickly.
Sorry, can you tell us what positivism and...
Yeah, so post-positivism is the idea there is a truth out there which can be discovered, but imperfectly. So we all come in with our biases, and a researcher, the goal of a researcher is to sort of remove these biases to uncover this truth. Versus constructivism is that there is no there's no one truth out there. Truth is constructed with our own experiences. And so the goal of a researcher is not to remove all biases, but to be reflective of their own biases and how that might influence how they're looking at research.
So,
Yeah, sorry.
I think that's a really interesting point. And you're making a really interesting point that when we look from different theoretical perspectives or different fields, we may be doing our research differently. But for me, this is pretty aligned with quantitative research, your post-positivism, and qualitative research, most methods of qualitative research. So I guess I just think it's, when we look at it from different perspectives, we use different terminologies. So I think it's what you're discovering is that there's different vocabulary. And I just want to make sure that we don't throw everybody off by, there's not like 100 different things out there. They're probably aligned to some extent. So
True.
I think it's an important point.
Yeah, but actually the next part I'll be talking about, I use a qualitative methodology, but the first one was more of a post-positivism framework, and then the second iteration you use more of a constructivism framework. And I struggle with this a whole lot as like, no, so it is true that it can be thought of as quantitative and qualitative, but even within the qualitative approach, it can have more or less of the other. So the hidden curriculum. So for that part, I'd like to thank Dr. Aliki Thomas from McGill University, who helped me sort of with a preliminary version of this project when I was a resident at McGill. Dr. Archibald, once again, Don Stacy and Paul Seguin, who are two international experts in shared decision making. Don works at the University of Ottawa and France at the University of Laval. Dr. Simon Keto, who's a qualitative researcher at the University of Ottawa, and then the Hess Group. So as I mentioned, this project really started all the way back in medical school, where I had the impression that medicine was being taught as a lot of black and white, with clear right answers, where really there was no right answers, and it was all shades of gray. And a particular topic which sort of I struggled with was the group A streptococcus pharyngitis. So for a non-physician, pharyngitis means a sore throat, and it can be caused by a number of things, including viruses and bacteria. And one of those bacteria is called group A streptococcus, and the issue of this bacteria is that it can cause some pretty severe complications of the heart, and it can be lethal. So therefore, the teaching is that group A strep, which is a small name for group A streptococcus, is a bacterial infection that causes rheumatic fever and that needs to be treated with antibiotics. The issue is that there's actually a whole lot of controversies regarding whether group A strep should be treated with antibiotics and whether it should even be diagnosed. And a number of guidelines, in particular in Europe and in Australia, don't advocate for treatment of group A streptococcus, and not even say we should even diagnose it, it doesn't matter. So why the difference? Because the incidence of this complication, rheumatic fever, is really low, so it's about 1 in 100,000. And that's actually quite in the same order range as the incidence of getting a bad complication from antibiotics. So really the teaching shouldn't be that group A strep is a bacterial infection that causes rheumatic fever and that needs to be treated with antibiotics. It should be that it's a bacterial infection that rarely causes rheumatic fever and that may be treated with antibiotics. And I think that those two little words make a big difference in how we frame this infection. So the original idea in residency was to evaluate how group A strep was being taught. The issue is I didn't have a framework to evaluate. So it's a nice thing to say, I want to evaluate what's good, what's bad. Sorry. I didn't have a framework to say what was good and what was bad. And then once I became sort of PGY3 scholar and had more time on my hands, I started to really look into the shared decision-making literature, which is a whole field of research, and came across IPDES criteria. So those stand for the International Patient Decision Aid Standards, and they are evidence-based and consensus-based criteria used to certify decision aids. Decision aids are documents that can be used between a patient and a physician to help with decision-making. So, for example, a decision for group A strep pharyngitis would have group A strep pharyngitis, should I take antibiotics or should I not take antibiotics? And then you would have the benefits of taking antibiotics and then the harms of taking antibiotics. And then a statement to help the patient make sense of their values and preferences to decide whether antibiotics is the right option for them or no antibiotics. So then the research question became, to what extent do teaching materials allow, so I can't point, but for shared decision-making by providing the requisite quality information. And the requisite quality information were defined by the IPDES criteria. So the methods was to use a sample of publicly available PowerPoint presentations on upper respiratory tract infections and to use quantitative content analysis using IPDES string codes. So for example, this used more of a post-positivism framework, even though I used qualitative content analysis because I considered my IPDES criteria to be the truth, and use them to evaluate my documents.
But where were the PowerPoints from?
So Google, and then some Metaportal, which is a repository of peer-reviewed curriculums. And so the results look something like this. So very simply, red is bad. So a number of the presentation had lots of reds. Green is good. So this presentation with lots of green is a presentation that was done by François Garret, so it is leader in shared decision making. And yellow is in between. So some presentations had more yellow. Those were presentations that had a specific focus on evidence-based medicine, on antibiotic stewardship, or that had been peer reviewed. The issue with this methodology, there's a richness that I wasn't capturing. So group A strep pharyngitis, whether it's caused by viruses or bacteria, is a self-limiting condition. It will go away. The rates of complications are really low. But they were being presented as really different entities. The viruses being good, the bacteria being bad. And then antibiotics were needed to treat the bacterial infection because antibiotics cure bacteria, not because antibiotics have been shown to be effective in this particular syndrome, which is how you should present it using certain evidence-based medicine and shared decision-making framework. But I wasn't really capturing those messages, and I thought that was a shame. And then I got a lot of pushback from physicians. So when I presented the results to the HETS group, it was just 100%, 99% pushback. So, which made me think of who's my target audience. So the methodology I had used made a whole lot of sense coming from the knowledge translation field. And actually a very similar methodology had been used to evaluate choosing wisely materials and materials for complete medical education. So
Tell folks what choosing wisely is, because probably maybe half might know.
So choosing wisely is sort of an organization that tries to think about common things that are done in practice and whether they have any benefits. So for example, for primary care physicians, they would say not to do imaging for back pain for the first 6 weeks, for example. And they've sort of grown exponentially, and they're quite well known within all of the different physician specialties. Sorry. So yeah, so my methodology sort of made sense in that field, and it would appeal to those researchers. But I didn't intend to make a paper for quality improvement, for knowledge translation researchers. I really wanted to talk to medical educators to sort of start this conversation of how we frame things and how we should be really using more evidence-based medicine and shared decision making. So, in order for medical educators to listen to me, I need to have a more positive message. I couldn't just come and say, I'm going to tell you you're doing things wrong. It just wasn't working. So I struggled with this until I came across a hidden curriculum, which right away I was like, oh, that's actually what I was thinking about without really knowing it. So the hidden curriculum is the understandings, customs, rituals, and taken for granted aspect of what goes on in the life space we call medical education. So the hidden curriculum goes at what students are learning instead of what they're taught and whether those two things are the same. Because we know that there are a number of unintended implicit messages that medical students absorb as they go through medical school, and that those messages don't always align with what the official objectives are. And so the question was, can I identify a hidden curriculum that's relating to decision making in my presentations? And to what extent is this hidden curriculum more in line with evidence-based medicine and shared decision making? So the research aims became to explore how decision-making can be conceptualized in relation to evidence-based medicine and shared decision-making frameworks. And then to provide recommendations on how to best align those messages with those frameworks. So the methods using the same simple PowerPoint presentations, but this time moving fully into the qualitative realm of research and in a constructivist approach. So the first step was to use theory-driven codes to identify materials that pertain to decision making. And then the second step was to reanalyze this coded material, but to go beyond the surface meaning of the words, to really implicit content, implicit messages that readers might gather from reading this material. So using a constructivist latent thematic analysis to develop a rich description of conceptualization of decision making in relation to evidence-based medicine and shared decision-making frameworks. So very briefly, the results showed that there was an emphasis on pathophysiological reasoning over clinical reasoning, that there was often a distorted conceptualization of evidence-based medicine, normalization of defensive medicine, and the utilization of harms of antibiotics as a bargaining tool. So in conclusion, I was able to make a hidden curriculum explicit in those PowerPoint presentations, and also to show that this hidden curriculum could be more or less in line with EBM and SDM frameworks, which is important because it actually might represent a new tool to improve the uptake of shared decision-making and evidence-based medicine. Limitations, so in order to have a cohesive sample of presentations, I only looked at URTI, so upper respiratory infections, which limits the generalizability. I only had PowerPoint presentations. I didn't have videos or recordings, so I can't say that the verbal messages align with the written messages. And only myself had the luxury of spending hours in front of those presentations. So there was only one quarter. But I did talk, so try maintaining reflexivity by talking with Delno a lot and Doug. And around that time, so I published a small opinion piece in BMJ, Evidence-Based Medicine, which sort of go back to those concepts. And in particular, the core focus of medical education to teach evidence-based medicine is critical appraisal. So asking students to formulate legal questions, to do systematic search of the literature, and then to critically appraise those articles. The problem is that it's not reflective of what's being done in practice. That's should be shown in lots of different ways. So in practice, sorry, I need to do So for point-of-care questions to be answered, they need to be answered at a point of care. Otherwise, they just never get answered. And at a point of care, secondary sources of the literature, such as Dynamite or UpToDate, are not only more efficient, they also give more reliable answers than using PICO questions and PubMed. And then the other problem is that it's a reactive approach to EBM, in the sense that we're asking people to sort of look back on their clinical knowledge, identify holes, and patch them up with evidence-based medicine, which might make sense in the 1990s when we didn't have a lot of EBM knowledge, but now this has changed. And so the idea would be to spend more energy, resources, and time into actually ensuring that there are no thresholds, that people graduate with best available evidence-based knowledge. And there is indirect evidence, such as the one I presented, that this is actually not the case. And so people, and one way to do this is to ensure that every teaching moment reflects the best available evidence, and to also focus on the clinically meaningful. So the whole purpose of evidence-based medicine is to have conversation with patients, to help them, to help counsel them through decision making. In order to do this, clinicians need to be able to quantify risk and benefits. And there's good evidence that physicians, residents, and patients, for that matter, are usually overestimate benefits and underestimate harms, which is an issue. And part of the problem is that this just isn't taught. So what does it mean to be a scholar? So for that project, to me, it meant following up with frustrations and taking ownership. So as I mentioned, it started all the way back in medical school as frustrations, which ended up one version of the project in residency. The problem is I didn't have a framework to sort of move forward, so it went on the back burner. It actually was one of the big drive for me to pursue the fellowship, so then I became a scholar, I had more time. Then I did one version of the project, which was use a quantitative, qualitative approach, which was good, but wasn't fulfilling my goal, which was really to start a conversation with medical educators, not with knowledge translation researchers. So then took some more time, more reflection, and then moved to a different approach, a qualitative, a constructivist approach to have a more helpful message. So personal growth interlude here, I really want to thank Dr. Hogg, whom I have called many times when I didn't know what to do, and has been really good in sort of giving me advice and helping me network. And particularly thanks to Bill, I started to collaborate with Lamont, who does a lot of great things, and they have a centre d'excellence en mutualité, where they try to sort of rethink of how we care for patients with multimorbidity. So this brings me to my last ongoing project. So acknowledgements once again, Dr. Hogg, Dr. Lamont, who's from Lamont, and then Dr. Brad, who's from McGill, started helping me also with the thinking about this project. So shared decision making is a good thing. It's an ethical imperative, so we all agree that patients should know whether the interventions that we are asking,
you want to leave a good 20 minutes for discussion.
Okay.
So you got, are you good 10 minutes from here? Or
Yeah, probably.
12? Okay.
So patients should know whether the medication that we're asking them to take are actually helpful. It's also mandated by regulatory bodies, so it's all over the Canvas framework also. And it packs care, so when patients are given a choice to do shared decision making, they often choose less screening. This has been shown for PSA quite well, for example, less elective surgeries and less hospitalizations. It's especially important for Medicare, because in that setting, we're asking patients to take medications or to undergo a test, not knowing whether they will ever benefit, despite the fact that they might suffer harms or negative consequences. And the reality is that most patients don't ever benefit. So here I'm looking at some big pictures, but just screening for breast cancer for 10 years, the number of screening is about 700 for the prevention of one breast cancer death. And using a statin for secondary prevention of cardiovascular disease for 5 years, the number of is about 100 for mortality. So most patients don't benefit. And it's also extremely hard to do. So as I mentioned, knowing the harms and benefits is difficult, so often we have to rely on best guesses. Guidelines often don't take into consideration shared decision making. This is changing, but for example, the latest guidelines published in CMAJ, the sea change guidelines, which are supposed to harmonize all the cardiovascular guidelines. The word shared decision making is present once in the whole guidelines. Lack of time, so using a patient decision aid as 2.4 minutes per patient, adding over many patients, that's too much time. And fragmented care. So there's no harmonized way of communicating the shared decision-making conversations. So one might prescribe a medication for the patient, and then the patient gets hospitalized for another condition and ends up on the same medication. And the reality is that in the field of shared decision-making, it has, and it still is, conceptualized as one decision at a time. But patients coming with a whole bunch of medical problems at the same time, especially in prevention. So there needs to be a way of looking at shared decision making across multiple conditions at the same time. Otherwise, it's just not feasible. So it's difficult. We know it's a good thing. We know we have to do it. But it's hard. But the beauty of shared decision making is that it can also be used to simplify things. We can remove arbitrary recommendations, long list of risk factors, etc., using shared decision making. So those were the simplified lipid guidelines published by Magdalene et al. In the CFP in 2015. And what we tried to do is to just look at the evidence and try to distill the decision of whether or not to start a statin to the simplest form using evidence. And this relies on knowing the cardiovascular risk, knowing the absolute risk reduction of statins, and asking the patient, is it worth it or not? And so this simplified approach has had tremendous success. So the guidelines have been accessed more than 100,000 times, which is pretty good. So the question is, can we build on this approach to make a pragmatic shared decision-making tool for the management of preventive care for patients with chronic diseases? And for that tool to happen, a number of things are needed. We need a way to quantify risk across a number of illnesses. We need a way to quantify relative risk reductions across a number of medications. And I won't talk too much about that, but I want to talk about this part, because we need a mechanism to ensure the tool is useful. So as I was writing this grant, spending many, many hours during nap time, the thing that really stuck with me is no matter how good this tool is, and it probably will never be perfect just because it's the reality of things, the likelihood that it gets used is very low. And it's really disheartening, but that's the reality of things. So this is the knowledge to action framework, which has been endorsed by the CHR. And there are two steps. There is a knowledge creation step and then the action cycle. And then the knowledge creation is really an inverted pyramid where you spend a bulk of the time thinking about the knowledge required in synthesis, and this gets distilled. And here I'm using the words of Sharon Strauss, who sort of wrote the book around that, edited the book around that framework. So it gets distilled into a tool. And the tool then gets implemented, and then you have iterative cycles. And when it doesn't work, the approach has been to assess barriers to knowledge use to sort of modify the behavior of the clinicians, for example, instead of modifying the tool. And this shows good efficacy. So in randomized controlled trials where people have incentives to use the tool, where they're being watched, you use the tool, and it does what it's supposed to do. So for example, increasing shared decision making. But once the researchers are gone, nobody uses the tools. So it has poor effectiveness. And maybe, once again, perfect is the enemy of good. So for knowledge translation initiatives, the approach currently is really the gold standard. So for example, for patient decision aids, there are the index criteria. There are a clear set of criteria as to what has to go into a decision aid. There are also Sunday reporting guidelines to sort of help design the decision aid and evaluating it. So there's been sort of proliferation of rigid guidelines telling researchers how to do things. And we should keep in mind the context. So if we're setting an interventional trial to try to figure out whether a medication is efficacious, then the gold standard, so the perfect methodology, is very important, because what we want at the end, we want to be as close to as we can as to having the answer, the truth. But point of care medicine is all the shades of gray. There's no such thing as the answer. So for example, I talked about risk prediction and quantifying relative risk for medications. I have zero pretension that I will ever be able to tell a patient in front of me, this is your risk, and if you take this medication, your risk will go from A to B. Because I'm using population data, and I have a patient in front of me with their own set of characteristics. So if the point estimate, say the precision of the point estimate isn't really what's important because it's all shades of gray, then maybe we should spend less time on the knowledge inquiry and synthesis and more time on actually figuring out a tool that works and adapt the knowledge to that tool. So sort of flipping things around. I'm almost done. So how could this be done in practice? I don't have an answer, but one way, for example, would be to use something which we know works. So here you can't see it very well, but it's a preventive care checklist form, which I've seen in different shapes and forms used in different provinces, different cities. So somehow there's something in it that physicians like because they use it. So to start with something that has been useful, and envision, so to add shared decision making and to add care prevention multimorbidity. And then to modify that tool, so to add this new knowledge, to eventually use it, find an adapted tool, which is more, not only has new knowledge, but is also useful for the point of care physicians and the patients. And then sort of thinking about this made me think about quality improvement methodology. So here we're is plan, do, study, act cycle, which is taken from quality improvement. And in my mind, quality improvement was really had encapsulated within the patient safety field. But it's actually, I think, a methodology which is quite underutilized. So what is quality improvement? It's essentially asking a practical question and thinking about the evaluation and how to make measurements in order to be able to evaluate right at the onset. So it's really the proof of quality improvement, is to thinking of evaluation as we're thinking about the question. Which brings me to my last point. What does it mean to be a scholar? Is it about research? Final reflection. I'm really. So the academic's role is quite clear that scholarship is about research. Those are the key features of the scholar role, and research is definitely there. But at the end of my scholarship, clinician scholar fellowship, to me, being a scholar means being empowered to challenge the status quo and to embrace change. And the important piece is this whole being empowered thing. Because there's two ways of doing this. There's research, and there are other methods, such as quality improvement. So what is research? The whole goal of research is to position new knowledge within established theories and framework, or to within the existing body of knowledge to help move it forward. Problems that this not rarely, but often doesn't get done because there's a lack of framework, unvalidated surveys, small sample sizes, etc., which aren't necessarily bad things. It's just that in the end, you don't help moving the whole body of knowledge forward, which was the whole point of doing the research. And even though it might not reach the goal, it remains extremely painful and extremely resource intensive. Quality improvement, on the other hand, is about improving systems within a local context. So practical questions, flexible methodologies, smaller scale, they are less resource intensive, and dissemination is so important. So this was published in the second last edition of the CFP, implementation of a patient-based feedback tool to assess kindness, compliments, and communicator role. It comes from a team at U of T who identified a need in their practice. They wanted to collect feedback from patients. And they decided to go the quality improvement route. So they did plan, do, study, act cycles over many years to make a tool which appears to be really helpful in their local context and which they now have disseminated in the CFP. So how can scholarship be nurtured? So the default has been research. When residents want to do scholarly work, the default is research. When clinicians come up with clinical questions in their practice, the default is research. Problem is that once again, by doing this, we might not be achieving the goal of research, but we do make it painful. So maybe we're actually squeezing the scholarly juices out of people. And then we might have better luck to fostering scholarship by looking more at quality improvement-like methodologies. Final words, going back to mindfulness. Scholarship, the cure to burnout. This is a letter that was published very recently in the CMEJ, so just in October. Change can start with a single person speaking out about a problem and finding a few other people who feel the same to share experiments and solutions. This, to me, is a seed of scholarship. And the question is, how do we foster the seed to make meaningful change happen?
Thank you. So we'll take 12 minutes to have discussion.
Thank you so much for your talk, Emilie. This was really, really interesting. A lot of information, a lot of different kinds of information. So I personally really appreciated it. I have a bit of a clinical question as a non-clinician. I don't know if you can go back, if it's worth going back to this strep A slide. Also referred to as strep throat, right?
Yes.
So I'm just, first of all, I really appreciated when you mentioned, the overestimation of benefits and underestimation of harms. I think this is particularly relevant when it comes to the prescription of antibiotics. There was recently another article, because there's been many in the CDC, about antimicrobial resistance, and I'm not sure to what extent that is sort of well recognized in the medical field. I'm sure it is, but I'm not sure to what extent, and the way it affects their practice. So I just want to understand, is there not guidelines as to how to treat strep throat? I know that there's a swab. I'm not sure if it's effective, but is it that if the swab deems that it's bacterial, then you're meant to prescribe the antibiotics? Are there physicians sometimes that don't even swab and give antibiotics without having a diagnosis?
So even if you swab, there are guidelines. So for example, something called a center score, which is a set of criteria that can be used to decide whether or not to swab and whether or not to give antibiotics.
Right.
So the center score says that patient has fevers, patient has red throat, patient doesn't have a cough, and patient has tender lymph nodes. And then if you have 4 of those criteria, theoretically, you shouldn't even swab, but you should give antibiotics. Now, don't want to put you on the spot, but so if you have 4 criteria, how likely is the chance of having group A strep, would you say? Knowing that your doctor has been told that he should give you antibiotics, she should give you antibiotics.
So if you have the fever, the sore throat, like all 4, how likely is it?
And then the guidelines say you should really be giving antibiotics because it's high enough of a, so it's 50%.
Wow, okay.
So, and if you have only a 50% chance of having group A strep, but you have a very high likelihood of getting complications, and those complications might decrease with antibiotics, it still makes sense.
Mm-hmm.
The issue is that in the old days, rheumatic fever was quite prevalent, so it sort of makes sense. But now rheumatic fever is really not prevalent, but the guidelines sort of haven't changed, which is why you have different national guidelines having different conclusions. And the issue is really that instead of presenting the evidence and presenting the quantification of risks and benefits, people are told what to do.
Right. So is there a reason why the guidelines haven't adapted to the changing context?
Yeah, because a lot of the trials that showed benefits were done in the States. A lot of the trials that did not show benefits were more European trials. This is another aspect, yeah.
I think there's additional reasons why this is out of step, and that is people who got rheumatic fever in 1940, when it was quite common, some of them are still alive today. So the experience of a clinician is that this is still around, and that it's very serious, and so that, you know, the incidence of new cases might be very low, but what we see in our practices, it's still there. Like, I bet you every family doctor in this room has got a couple of people who have rheumatic fever.
And I must add, sorry, to caveat that in certain populations, such as Aboriginal populations, for example, rheumatic fever is much more prevalent, so this wouldn't add in that context. But the reality is that, so the latest, so since, I'm going to make it up, in the 1980s, there have been 2,500 patients studied in randomized control trials, including 1,000 controls, and none of them have had rheumatic fever.
So is it that we have so much better nutrition that the same infection is not?
So the idea is that it is linked with SES, with socioeconomic status and chronic conditions. Yeah, a bit like TB. Sorry, yeah.
I was going to say 2 things. One, I think is that there's a fear instead of clinicians, right? If you said, I actually have a patient with rheumatic fever, it's like a low-risk patient, maybe you want to have rheumatic fever, it's not pressures. If you were not to treat it and someone were to get it, you'd be screwed, right?
Yeah.
Absolutely screwed. But then I kind of shift gears, and just ask about, I love your statement, squeezing the skull and the juices out of people. That's what I feel we often do with our FMRSP program as it stands, right? So I'm curious if you have any insights.
Here's the
Oh, sorry, can you hear me? So, because I'm wondering if you have any insights, because I feel like we do that a lot with our FMRSP program as it is right now. Right? People are either anyone who dives in ends up going deeply depressed by their end. Can you make any suggestions from your research on how we can do this to improve the experience of the research or scholarship experience of residents in our program in the 2 short years?
Could you repeat the question, Emily?
So the question, so a lot of so residents have a negative experience from this kind of work, and how can we make this a more positive experience? So I think, I think that defaulting to research is where the big problem is, and then having sort of other rigorous methodologies which have evaluations, think about evaluation, which is what we want at the end, is to know whether what we've done actually did something, is important. And this is really, I think we should really look at the quality improvement methodologies and whether we can use those more effectively in our day-to-day practice and questions that arise from clinical practice.
Yeah, I totally agree. Because often we end up defaulting to letting people do the literature review because they run out of time and that's not scholarship. That's basic skills.
And then the thing, I think scholarship is a way of life. And it's sort of being, so it's seeing problems and wanting to do something about it. And if when you want to do something about it, nothing ends up happening, you end up being depressed and you end up sort of not doing anything. But so, yeah.
La prochaine?
There's actually a great book on leadership, which is called Multiplier, which talks about how we can squish people, so diminish people, and this is, I think, ready for research, we're actually diminishing people.
So there's a fellowship in Canada called the Tudor Fellowship, and I'm presently helping facilitate a discussion around logic model, and so the trainees are asking research, program evaluation, quality improvement, there's so much overlap. So I think what you've identified is a real issue. But I think that we are no longer doing these, or we're only doing these big R research. First, we're doing more pragmatic trials. And second, I'd like you to consider the possibility that the reason why quality improvement might appear to be a better approach in dealing with things is because to do quality improvement, you have to engage the folks in the context and helping address what they would need to make things better. But that's what we've been asking, or we have been asked to do in research, is to engage our stakeholders. And if we had engaged the care providers who we would want to have implement those tools, we might have come up with better tools. So I'm not sure the answer is quality improvement. I think there's some aspects of quality improvement that make the outcome more palatable or more appropriate. But it is, again, context specific. And for something to be broadly applicable, we may need to go to research, but, again, with a broader engagement.
So I think a quality improvement is also a way to engage, just by having, even within research. A paper published in one of the JAMA journals, where they used quality improvements, so they were looking at the use of laparotomies in the immersive room to sort of define what their question was, what their problem was, and from using sort of multiple cycles of quality improvement, they then went into big R research. And I think looking at it that way, where people are engaged in a more of a rigorous manner, because now there's either nothing or everything. There's sort of not in between. And then this is sort of allowing the in-between where...
So that may be, I don't know, educational research, but I would have to say that in health services research, we have been engaging our end user more. So we've been engaging patients more, we've been engaging the policymakers, because in the hope that they would apply, so it has to make sense to them. We've been engaging care providers. I don't know the field of educational research.
So there's definitely a push to try to engage people. Whether this is actually resulting in better research, I don't know if we know that yet. So the IKT pathologist, for example, is all in flux. But there's definitely push from researchers to have a lot of rigidity into how things should be done. So there's a proliferation of reporting guidelines, a proliferation, which might be a good thing, but might also be impeding grassroots initiatives, which might actually be more useful.
Thank you so much for your talk. It was very informative. I just have a couple of things. One, coming back to your hidden curricular research, you said that you faced pushback from clinicians when you discussed this disparity in treating strep A. What did they say to you exactly?
Well,
were they critical?
Yeah. So, well, in some ways, it's a bit of the feedback that we got from Bill is that, well, what if you miss a case? What if I'm a patient whom I didn't treat and end up having my fever and I can't sleep anymore? So there's a lot of that, I think, which is a bit, in some ways, still, even because the reality is that even if your patient had a fever and you didn't treat them, even if you had given them antibiotics, most likely the antibiotics would not have prevented a fever. Because it's easy to overthink that we can cure patients, but really, yeah, sorry.
No, go ahead. Okay, thank you. Another thing. So, in your research, did you have that reflection or thought that the evidence in evidence-based medicine is now a bit flawed, and that evidence-based medicine is no longer glorified the way that it was 10 years ago, and that maybe, like, as you're saying, the thinking should be shifted into more critical thinking and to change the way clinicians are taught, and If yes, then how would that help with quality improvement?
So it depends on how you conceptualize evidence-based medicine. If you conceptualize evidence-based medicine as rigid guidelines, and that you must do what the guidelines do in order to be evidence-based, then this is not my conceptualization of evidence-based medicine. And I don't think that it was a conceptualization of evidence-based medicine in the 1990s. And actually, the definitions of evidence-based in the 1990s clearly talked with the patient, and that the goal of evidence-based medicine was to have conversation with patients. This sort of got lost a bit as more of the epi came in, and now it's going back towards sort of shared decision making and how to be considered that, once again, there is no, we might have a population-wide evidence, even though you might still change 2 years down the road, but for the patient in front of you, this evidence needs to be taken into context.
I have a question about the curriculum as well.
Yeah.
So the slide that you had, the conclusion or the findings, can you go back to that slide?
Sorry, which conclusion slide? Because I had a couple.
On the hidden curriculum.
Yes.
Yeah. So my question is around kind of the next step. So once you've made knowledge that is implicit in practice, more explicit, what are the next steps from an education perspective for clinicians in addressing the hidden curriculum? So, you know, there's both positive aspects to hidden curriculum and ones that are less positive. So what are some of the actions that you would take in terms of next steps to address it?
So using sort of the analysis, I made some recommendations as to how to use evidence-based medicine and decision-making frameworks in PowerPoint slides. So the next step is to disseminate this work and to hopefully have less of a pushback and more of a, oh, let's try to see if this works for us in a context. So this is sort of, at the end, I have sort of concept maps of how to think about PowerPoint presentations and to use more of those concepts.
Well, thank you very much.
Thank you.
This was a great discussion. We'll resume back